Okay, so I thought we'd start with a little history lesson here before we go into this case. So when I was doing this case, I got stuck in the Greek origin. The story of Scylla and Charybdis struck me with the Odyssea in Homer's Odyssey. So after the Trojan War, when he was heading back to his island in his ship, he came upon this passageway with two big rocks. One on the one side was this rock with a cave with a six-headed serpent that he was afraid was going to attack his ship. And on the other side was a big rock with this whirlpool that he was afraid that if he actually went there, it would sink his ship. That was Charybdis, the six-headed serpent is Scylla. So he really felt like he was stuck between a rock and a hard place. And you'll see what I mean when I say I felt the same way. So this was a 72-year-old male with a past medical history of coronary artery disease, peripheral artery disease, diabetes, atrial fibrillation, sixth sinus syndrome with a pacemaker, who presented with progressive dyspnea and exertion and was found to have a non-ST elevation MI. Troponin was mildly elevated, BNP was elevated. The electrocardiogram showed infralateral ST segment depression. The echocardiogram showed preserved left ventricular systolic function with mild inferior wall hypokinesis. Coronary angio demonstrated a calcified and a severe disease of the right coronary artery. Otherwise, there was non-obstructive disease in the remaining arteries. So here's an injection of the right. You can see heavy calcification, particularly in the mid-RCA, high-grade stenosis, distal RCA, and the ostial, the PDA. When we look at the left system, otherwise non-obstructive disease. So our approach, we were planning on doing a rotational atherectomy using a 1.5 millimeter burr of the calcified mid-right coronary artery, followed by stent placement. And this case I did do with a fellow, so I'm going to blame it on the fellow. So great fellow, but very eager and excited. And as you know, when you come up to a calcified lesion, you got to do peck. Well, he decided to do the 18-wheeler Mack truck and just laid right into the lesion. And right when we got into the lesion, the burr stopped. It was stuck. Wouldn't go forward, wouldn't go back. It was just stuck. So just to refresh everyone's memory, when you look at the Rotablator burr, the first half has the diamond burrs, which performs the atherectomy. The back end is just metal. It's smooth. So if you cross a ledge and get past that front ledge of the calcium, you can't rotablate backwards. It doesn't work. And so just something to be mindful of. And so while we're sitting there at the cath lab, thank God we just installed, these super fast computers in the cath lab. I'm like, can someone please Google the manufacturer's website and see what their troubleshooting recommendations are? So this is really word for word what it states if you go to their website. If the burr is lodged in the lesion, cease rotational atherectomy and careful attempt to remove the device. We tried that little jiggle forward back, didn't do anything. Never attempt to start the burr spinning if it is stalled within the lesion. Well, we did try that. We tried to actually spin it.
Everybody tries.
Yeah, everybody tries that. We try to spin it and try to go forward, and it wouldn't go anywhere.
The reason for that, though, real quick, is that you don't want to cut the wire. So, but everybody does it.
Yeah. So, and then, they list. This is what they list. Don't pull on the catheter. We tried. We weren't forceful, just gentle. It didn't work. Administer nitroglycerin. We tried that just in case there's vasospasm. Didn't work. Wait 30 seconds. Well, we're in a bunch of cardiologists. We have about 5 seconds. And we tried dislodging the burr again. Didn't work. Use a buddy wire to go past the burr in the stenosis distally, then try to balloon it. And that we did attempt, and I'll show you some angios of that. And then use Dynaglide foot pedal for a quick burp. Remember, Dynaglide doesn't reverse. It just has a lower rotational spin to it. So that didn't work. We did try it. Okay, so we got contralateral axis from the femoral. And this is a JR4 guide. We wired it with a Cougar, went pretty easily down, and then we got a 1-2 balloon. And we got it as far as we could, but we couldn't really get past that proximal edge of the calcium. But we did balloon dilate, and after that, we tried to push-pull on the burr with no success. So then we went up to a 2-0. Again, if you look at the balloon distal marker, you can see it's not really past the Rotablator burr. We just got it right into that proximals as far as we could get it, but we were hoping we can change the conformation of the calcium enough to be able to retract. Again, after the 2-0, after the 1-2, this was actually a 2-0, no success. We went to a 3-0. Again, tried ballooning, and after that, we tried to pull back or forward, and were unsuccessful. So then we pulled the wire of the Cougar, and we actually spun, did a rotational atherectomy to see if we can actually move it at least distally, so at least to get it dislodged, and the thing just wasn't moving. Okay, so what we tried.
Did it spin?
What's that?
Did it spin?
No, it was grinding.
So,
Yep. Yeah,
Dean,
it
did
was
you try,
stalling.
at this point, I just had this happen to me, and it's a terrifying feeling. Hopefully the patient was stable. Did you try getting at this point, you can cut the wire. I know you're not supposed to do this. Cut the wire and get a guide liner over it, and try to get a guide liner around it, and then be able to pull. And we did that with a trap balloon, and really were able to get it out.
Yeah, that's next line. Dan, actually, I'll show a slide on that and how to do it here shortly. So what we did do, and we didn't document this, of course, is we put our big boy pants on, and we took that guide catheter, and this is from another case report, and we deep-seated it. We deep-seated it just proximal to the burr, and I will tell you, we pulled with force. And this is not something you should attempt right off the bat. You can perforate, you can tear the artery, it can be catastrophic. I will say that we did have cardiothoracic surgery from the get-go into the room as backup when we attempted this. And when we did attempt this, we got very lucky, and the burr came out. And perhaps some of the ballooning we did helped facilitate that. It's hard to say, but I will tell you it was a little bit of a forceful pull. Afterwards, we went ahead and ballooned distally and in the mid, used the guide liner for support, stented the distal vessel, stented the mid. And here's our final image.
Your rotablator wire, you got the burr out, and left the wire down?
No, everything came out with it. When you pulled, it was force. Everything came out with it, so we lost wire position. But I'm going to show you a couple techniques where you may not have to lose wire position here, and one that was just mentioned from the panel. So anyways, we got lucky. The patient was hemodynamically stable. The result, we stented the mid, the distal. We got lucky on this one, and the patient did well. But just to summarize some of these different methods. So intracoronary nitroglycerin or verapamil for possible coronary vasospasm. We tried that, didn't work. Increased rotational speed and attempt to advance the burr distally to get it dislodged. We did attempt this, did not work. You can do a balloon dilatation at the site of the trapped burr. There's two different ways to do this. The first one is you can advance a second guide wire past the burr, followed by balloon dilatation alongside the burr, which we did, and we did get contralateral access from the femoral artery to do this. Unsuccessful from our attempt. Another way you can do it is if you can't get a second guide wire past your burr and the stenosis, you can actually do a modified, it's a subintimal tracking and re-entry technique, the STAR technique, by placing a second guide wire in some interval space and re-entry and then ballooning in the false lumen. Here was a case report that was done that kind of shows that technique, the balloon in the false lumen, dilating it to get it dislodged. This was a successful case that was published. You can also do manual traction, which eventually worked for us. A few ways to do this. One way, you can disengage your guide catheter, then advance another guide wire like a 035 into the aorta. And while you pull this, this will inhibit the guide catheter from deep seating in the proximal vessel and tearing it potentially. You could advance a stiffer guide wire if able, which typically this is difficult to get a stiff wire past that burn, the calcified lesion. If there's some angulation to help straighten it to decrease resistance, and then pull. And the last one is what we did is we just we did a deep engagement of the guide catheter proximal to the lesion, and we pulled back with some force. Again, it can be risky. This is the method that was discussed. And if you look at the advancer on the bottom right, you can see the drive shaft connects to the advancer right at the tip here. And what you can do is you can cut the drive shaft sheath, which is over the drive shaft, and then the rotational atherectomy wire, which is obviously it's over the wire, and you can detach the two. By detaching that, then you can actually take the sheath, the drive shaft sheath, which lies over the drive shaft, and peel it out, which takes up 4.3 French. So this then allows you to have more space in the existing guide catheter to advance another guide wire, advance a balloon, and without having to get additional access. It also gives you more room to place a guide liner that was mentioned, and even a snare to help with more direct pulling force. Laser atherectomy has been described, and obviously cardiac surgeries we kind of use as our last resort, but we did have them on standby, and it was helpful to have them there. So in summary, appropriate technique is very important. This was a result of forceful pushing into the calcified lesion without a pecking, back and forth. Burr entrapment is a potential complication to be aware of, and several techniques we described here that can hopefully bail you out of that. And I hope that no one here has to face Scylla and Charybdis in the cath lab.
That's great. Thanks. You know, just two comments. One is that the reason that you can't pull so hard is because that sheath is really, really flexible, and it's like an IVUS catheter sheath, and so if you pull, it'll just keep stretching, 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 and you're actually not transmitting your pulling force to the burr itself. That's why some of these other techniques are possible. The one other thing that we actually use as our go-to method, which is not any of these ones, is the totally counterintuitive thing of pulling back on the wire. The weld on the rotowire that prevents the rotoburr from going distal is actually super strong. And if you pull on the wire, which is totally counterintuitive, and you basically pull hard, you'll basically employ direct force on the Rotablator burr itself, and it often comes out immediately right away. This was something that I trained in a place that didn't use that technique, and then moved to a place that we do use that technique, and honestly, the stress level is so much less when you do it because it comes out quickly. The only problem is that sometimes you do that and it still doesn't come out, and if that happens, then you have to do all of this.
Yeah, that's a great point. Actually, excellent point.
It seems to me that since you'd already had the wire past it, the other wire, the Cougar, whatever it was, that you only, and it's easy to say here, maybe I missed it.
Yeah.
It seems before I yanked on anything or pulled hard on anything, I would have wanted to have that wire and that other access down as a prevention.
Yeah.
Or,
That-
there's something.
Yeah, no, that's a good point. You're absolutely right. And actually, what we were thinking is that after we did all the manipulation of ballooning and whatnot, we wanted to re-roto and see if we loosen something up. So we pulled that wire back because of that. But
Before you did the final
yeah,
successful pull,
yeah,
that would have given you access to
absolutely.
ruptures.
Yeah, absolutely. That's a good point.
I think
There's an issue with Rotablator through trying to treat a jailed diagonal, for instance, and you've got stent struts. The Rotablator has no ability to cut in the backward direction. The company should maybe address that. But if you've gone through a stent strut, popped through, it
Yeah.
can be very difficult. And I had to put the guide all the way down to the diagonal in order to push down enough so it would come back. The other thing is the CSI will stall by wrapping into that can be bailed out by separating it and rotating it in the counterclockwise direction, and then you can get that device out. I've never tried that with the Rotablator because I don't think it wraps into the stall very often. But at least in the multi-link variety of the Rotablator, you have that ability to separate that thing, and then you can spin the shaft the opposite direction.
Yeah, that's a good point.
And it might be helpful.
Yeah, that's a good point.
Dean, that's a great case. There's also a nice review on this. You said on the computers. I was trying to Google it too myself at the same time a couple weeks ago, and then realized there's one in Cath Lab Digest that Moore Kearns kind of hand out on how to handle this. And when it happens, the amount of force, I'd never had it happen to me before, and the amount of force, you're right, is so terrifying when you do it. It's good to have that other ping pong technique so that if you do have a perforation, you have the ability to get down with something else. I actually cut my finger on the wire. I pulled so hard through the glove, and it's just one of those gut-wrenching.
Very soft skin.
Soft skin. Yeah, I'm sensitive.
Drew, it helps if you put your foot on the table too, you know? But
Yeah, I was going to show a picture of Hercules, with his foot on a table pulling. But yeah, it is forceful. It is nerve-wracking, I will tell you, and you don't know what you're going to cause. It's so I think having another wire down said both very good points from both of you. Yeah.
yeah, I mean, our algorithm, we don't do the other wire first. We quickly give a quick pull with the wire. If that doesn't work, and obviously if it's super tortuous and you're gonna have a hard time getting back, then you might not do that. But if it just doesn't pop back that way, then other wire, that sort of thing. But oftentimes you don't even need to have that. Awesome, thanks so much.